Hello, and thank you for joining us on World Cancer Day 2022, a day when we celebrate and discuss all things cancer related. And what better day to focus on the topic of raising awareness of prostate cancer with and for Black men. My name is Lou Taylor, and I'm your host for today. I'm the director of Black History Month South, which is a community interest company based in Southampton. And we've been supporting the prostate cancer campaign locally for a number of months now. We welcome you to this webinar and hope you'll find the discussion informative, myth-busting, and most of all, that you'll take away some information that you didn't have before and can share it with your friends, families, loved ones, and communities. Please note that we are recording this webinar today. Now, if you have any technical difficulties during this webinar, please contact Louise Harbert. I'll spell Harbert, that's H-A-R-B-E-R-T, on louise.harbert@healthandcare.org.uk. That's louise.harbert@healthandcare.org.uk, or message us using the chat function. We are welcoming questions throughout the webinar. Please use the Q&A function, which you'll see at the bottom of your screen, down there somewhere, and simply type your questions in or comments, and we have a team monitoring these, and we'll try and get through as many of them as possible during the session. Any questions we receive that we can't answer, we'll send a follow-up email after this webinar and provide all the relevant information along with useful links that you may wish to explore in your own time. So let's crack on. May I introduce to you our speakers who are with me today to help aid the discussion around prostate cancer. Firstly, we have Susan Piper, a specialist nurse from Prostate Cancer UK. We have Professor Frank Chinegwando, MBE, who is a consultant urologist. Duke Harrison Hunter, Equality Officer for Pompey in the community. Dr. Richard Roop, Cancer Research UK Primary Care Advisor and Wessex Cancer Alliance GP Advisor. And we have Hugh Murray, a prostate cancer survivor and member of the Prostate Cancer Campaign Project. Thank you all for being here today. So let's get straight to it. And Susan, may I ask you first to tell us some of the key facts about prostate cancer and what are the risks?
Yes, absolutely. And a very good afternoon to you all. I'm very pleased to be here representing Prostate Cancer UK. So prostate cancer is the most commonly diagnosed cancer in men in the UK. And the reason that we're all here today is because Black men are twice as likely to be diagnosed with prostate cancer as men of other ethnicities. So in the UK, on average, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. This rises to 1 in 4 in Black men. Now, we don't really know why this is the case, that Black men are at this increased risk, but it's thought to possibly be due to a genetic cause. Now, prostate cancer affects men mainly over the age of 50, but we know that Black men are more likely to be diagnosed as a slightly younger age and can sometimes be diagnosed with more aggressive cancer. So when we talk about prostate cancer being aggressive, we're talking about a cancer that's more likely to be able to do harm to that individual and is more likely to be able to spread, making it more difficult to treat. So I just want to consider symptoms now. And it's important that men, particularly over the age of 40, if they're experiencing any persistent or recurrent problems or differences in the way that they urinate, that they should consider consulting their GP to help them understand the cause of their symptoms and to be able to rule out a more serious cause. But it's also important, just on balance, to say that many men will be suffering from a benign or non-cancerous condition, such as enlargement of the prostate. I really want to highlight here a fact that very often during our work on the specialist nurse line, that people are very surprised to learn that in actual fact, in early prostate cancer, we typically don't expect any symptoms. So that's why in a condition where there may not be any early warning signs, it's particularly important that men are aware that they fall into a high-risk group. So we recommend that men, Black men, from the age of 45 shouldn't expect or wait to see symptoms before being proactive in considering contacting their GP to talk about their increased risk. Let's just consider some other risk factors here. Increasing age. So the older a man is, the more likely they are to be diagnosed with prostate cancer. And also having family members diagnosed with prostate cancer, especially if this happens to be a close relative, such as a father or a brother. And we also know that men who are particularly overweight are more likely to be diagnosed with more aggressive cancer or cancer that's already spread to other areas of their body. Now, to help individuals understand more about their risk, Prostate Cancer UK has developed a 30-second online interactive risk checker, which allows a man's age, ethnicity, and family history to be entered. And we'd like to encourage men and concerned others to use and share this really helpful tool, and it will enable them to learn more about their prostate cancer risk. And you'll also find some really useful information to help men make an informed choice about what action they might like to consider next. Now, it's very important to highlight that prostate cancer is not just one disease. It comes in many forms. So for many, it will be a slow-growing disease, but can also be fast-growing in some individuals. Prostate cancer is sadly responsible for the death of around 11,500 men in the UK each year. I'd like to just end by sharing perhaps one of the most important take-home messages of the day, and that is to emphasize that when prostate cancer is found early, it is one of the most successfully treatable cancers that we know. So early diagnosis is more likely when there are good levels of awareness, particularly amongst high-risk groups. And hopefully after attending today's session, I'd like to think that you'd all feel more confident in sharing this knowledge and encouraging conversations within your own family and friend groups. Thank you.
Thank you, Susan. That's fantastic. We have a few questions that have just come in. We'll just run through some of these if you're happy to answer them. The first question is, how can I avoid prostate cancer in my family?
That's a very good question, but unfortunately, no one actually knows how to prevent prostate cancer. But a healthy diet and lifestyle may actually be helpful. You may recall that I mentioned about men who are particularly overweight being particularly susceptible to be diagnosed with perhaps more aggressive disease or disease that's already spread. So really, all we can suggest is that men have a healthy, balanced diet. If they're overweight, try to get down to a healthy weight, or try and maintain a healthy weight by being as physically active as they can. It isn't possible to change other risk factors, such as age, ethnicity, and family history, but of course, we can have some control about our diet and our weight in the majority of cases.
Thank you, Susan. And I'm just going to hand over to Gemma or Louise, who are on our support, just to go through a couple of the other questions.
Hi, Lou. Yeah, we've had a few questions come in. Thank you for everyone who's submitting those. One question was, does proactiveness include an annual health MOT with my GP? So
we don't have a screening program for prostate cancer. And so I'm afraid we do have to rely on individuals coming forward to be proactive and seeking sort of the sort of advice of their GPs. And so there isn't anything that's sort of regimented that men will be called in for. But although we recommend that men, as I said, Black men age 45 and those men with a close family relative do be proactive in approaching their GP to talk about the risk and discussing sort of the next steps, which we're going to hear more about from our GP colleague, Richard. Men over the age of 50 have the right to be able to request a blood test, which we'll hear more about in just a moment. But that should really only be after they've had the opportunity to discuss those advantages and limitations of that test.
Thank you very much, Susan. And thank you for all the questions. And there are a couple more, but I am going to move us on. And we'll come back to these at the end if we have time, or if not, as I mentioned at the start, we'll send an email with answers to all the questions we received.
Lou, I'm so sorry, you're on mute again for some reason. So just rewind a second, just check your mute.
If I may, there we are. If I may, I'll now move on to Dr. Richard Root. Richard, you're here to talk to us about where the prostate actually is and what to expect when someone goes to see their GP with a potential prostate issue.
Thanks for the intro, Lou. It's great to be with you and a real privilege to be able to join such a great team. And today being World Cancer Day, really important to focus in on what is the cancer that generates the largest number of cancers in the UK. So what is the prostate gland and where is the prostate gland? Well, the prostate gland lies immediately below the bladder. It's about the size of a walnut in a young man. And as we all grow a bit older, it does enlarge with age. The urethra, the proper anatomical term, or the P-pipe, goes right through the middle of the prostate gland. So it's almost a bit like a ring donut, and the P-pipe goes straight through the middle. And this explains some of the symptoms that you get when the prostate gland starts to enlarge. When it enlarges, it can grow inwards, which can reduce the diameter of the P-pipe. So that means that when you wee, the flow is generally a bit slower and takes longer for you to empty your bladder, and sometimes it can stop-start a little bit. In addition, if the prostate gland is growing upwards, it then puts pressure on what's called the neck of the bladder, and that can make you want to wee more often, and particularly that's noticeable through the nighttime. In terms of the functions of the prostate gland, it's basically tied in with sexual function. So it produces some of the fluids that the sperm are then able to swim in. It also adjusts the alkalinity of the fluid so that it can then counteract the fluid within the female reproductive tract. And so it's all tied in with that. It also has some role to play in the sensation that a man feels during sexual intercourse. And also the gland has some hormone function, producing some of the hormones also associated with sexual function. So that's basically the prostate gland, where it is and what it does. One of the challenges we have, which we've already heard earlier, is the blood test that is used, the PSA, is not specific for cancer. It will also be seen with the aging benign enlargement of the prostate gland. It would be great if we had a prostate cancer specific antigen, but as yet we don't have one. The researchers are trying to do lots of clever things to find if there are alternative ways of detecting prostate cancer, which would make life a whole lot easier. In terms of what to expect when you come to see us, your GP, or increasingly now, your first contact may well be by an e-consult or a telephone call or a video call. The first thing that will happen is the GP or one of their nursing colleagues or one of the other clinicians will run through your symptoms, also obviously your heritage background and whether you've got any family history, particularly whether there's been a prostate problem with your father, or if you have any brothers, whether they've had a similar problem. And then depending on the circumstances, they may arrange a blood test first and then bring you in to examine you, or they may ask you to come straight into the examination and then arrange the blood test after that. So that's roughly what to expect. The examination, depending on what's gone before, may involve pulse and blood pressure, as we quite often do, but then may also involve an abdominal examination. And just occasionally, if it's required, we may have to check out the prostate gland, which is actually done through the back passage. So that's what to expect, and depending on the findings, your GP or the nurse or the paramedic practitioner would then arrange for that blood test, or if necessary, an onward referral to our urology colleagues in the hospital. And that's about it for the narrative that I'm going to be taking part. So really keen to receive any questions you may have on what I've just discussed.
Thank you, Richard. It's really informative. So we have a couple of questions that have come in. One attendee has asked, is 80 too old? I think they mean too old to get checked. What would be your advice?
No, absolutely not. You're never too old to be checked. One of the really interesting things with seniority, to call it that, is that it doesn't necessarily reflect how many years you've got ahead of you. So you can be quite young at 80, but there will be some folk who can be quite old at maybe 65. So whatever your age, really important. And as we heard earlier, because one of the biggest risk factors for prostate cancer is advancing years, it's really important as a senior that if you do have symptoms, get checked out. It may be that your symptoms are related to that prostate growing with age, but it could just be a cancer, and really good to catch that early if we can.
Thanks, Richard. And also one other question for you. Lots of men will have heard that if they go to their GP to talk about their prostate cancer risk, they may have to have a DRE, which is a digital rectal exam. What message would you give to men who might avoid going to their GP?
I would say that it's not a great examination. It's uncomfortable. I think quite a lot of guys are worried about what the GP may be thinking or worried about. For a GP, particularly a male GP, it's part of our everyday practice. And although we appreciate it's a big thing for you, for us, it's really not a big thing. It's just a part of what we do. And one of the things that's sort of a bit lavatorial, but the gloved finger is considerably smaller in diameter than a poo. So it's not actually terribly uncomfortable. It's just a bit inconvenient, and it's just sort of invades our privacy. But in terms of the actual discomfort, it's not a painful procedure at all.
Thanks, Richard. I'm just going to hand over to Gemma and Louise to see if there are any other questions that have come in.
No more questions at the moment. Thank you, though.
Thanks very much. In that case, let's move on. We're going to hear now from Duke, who has kindly joined us today. And the question you've just answered, Richard, is probably something Duke can relate to, as I believe he had some initial reluctance about going to see your GP, didn't you, Duke? Please tell us more.
Hello, everyone. Hi, Lou. Thank you very much. And welcome to everybody on the webinar for World Cancer Day. So yeah, well, growing up, I heard about prostate cancer for a number of years. And and when my dad and my mum are from the Caribbean, a lot of the time when you mention prostate cancer and the DRE, the digital rectal exam, there was lots and lots of homophobia around it. So the message I was getting was, like, do not go to, I am going to get a prostate exam because of the rectal exam. So I grew up believing that for a number of years. And during that time, even going to doctor's surgeries, there was nothing on the walls or any magazines to say, basically, Duke, as a black man, you should be going to get checked, because a lot of the campaigns were were done with people outside of my colour. So I didn't really resonate to that. So it wasn't until my dad, who's just recently back from Jamaica, who now has prostate cancer over the last 5 years, told me about it. And he was always telling me, you should go and get checked, you should go and get checked. I spoke to my mum, I spoke to my daughter, you should go and get checked. And it wasn't until I came along onto the Dorset Race Equality group alongside the Wessex Cancer Alliance group, and speaking to some of the specialists within those groups. And they mentioned the PSA. And I thought, well, what's a PSA? Because in my head, when you say prostate cancer, I just automatically think of digital rectal exam, which would stop me from going. So they explained what the PSA was. Simple blood test. I thought, okay, I'm going to give that a go. So I made an appointment for for a PSA. Went to see my GP. Was down there I probably spent more time in the waiting room than the actual blood test, which was done in like 5 minutes. And I think my count was -1. So there was no traces of any prostate cancer. And I thought to myself, if I'd known this information a long time ago, I would have passed this information on to a lot of my friends and said, you know what, it's so easy. Just go and get it checked. Because of the DRE was the main phobia that I had, because I was that person. I was very homophobic about it and just didn't want anyone touching me at all, as Dr. Roop just touched on, because of the homophobia and because of the way a lot of the guys, I suppose, in the Caribbean islands think about having someone do that to you. So it can be quite embarrassing. So it doesn't really matter who does the exam, it's just the fact that you're going in there having it done. So a lot of us were going, nah, no way, not having it done. Ego's kicking in, no, not having that done at all, until the PSA came along, and that was the best thing ever. Once speaking to the specialist, and it's so easy. It's so easy. Just make an appointment, go in, have a blood test, and within a couple of days you'll get your results. And I'm sure if there are any further tests that need doing, your GP will contact you. So yeah, if you're out there and you're like me, please go and get it done. There's nothing scary about it. If you've had your blood test done before, it's just very simple. 5 minutes of your life.
Thank you, Duke. I think there are some people who relate to what you've just described, and hopefully what you've just said will encourage and reassure other people to go for their PSA test. So let's take a quick look at the comments and questions that have come in. Gemma, Louise, are you there? Is there anything we need to pose to Duke right now?
Hi there, Duke. Yeah, thanks for talking about your experience of taking a PSA. There's been a few questions about symptoms. And Professor Frank has kindly kind of answered that in the chat, really. So just to summarise, there can be no symptoms for prostate cancer. So he's just said that there is a real value in getting the PSA blood test. If there are symptoms, these could be things like maybe having difficulty passing urine, or kind of going to the toilet a bit more frequently than normal.
Louise, can I just interrupt you briefly? Your audio is breaking up somewhat.
Can you hear me
there?
Is that Gemma?
It's Gemma, yeah. Can you hear me?
Yeah,
okay?
Gemma, you are very clear, Gemma. Yeah, it's
Brilliant.
just Louise was breaking up. So
sorry about that. So just to clarify, the question that came in on the chat was around the symptoms of prostate cancer. And we've had an answer in the chat as well that says that there may be no symptoms, which is why there is such value in having your PSA blood test and going and requesting one from your GP. However, some symptoms that you may experience could be around difficulty passing urine or going too frequently to the toilet. There was another question in the chat around what a normal range would be for a PSA score. And again, that's kindly been answered by Professor Frank, who has said that generally the PSA should be less than 3, but it would depend on age. So thank you for those questions.
thank you, Gemma. So I'm greatly encouraged by all this engagement and on the topic. And I just want to share a little bit about my own experience of seeking a PSA test. So going back probably about 6 or 7 years ago now, I started to develop a few symptoms. I was waking up in the middle of the night, trying to go to the toilet, not able to go. So I requested a PSA from my GP. And at the time, when I went to see him, he seemed to want to discourage me from having a PSA test. I don't know what his reasons were, but I mentioned to him that as a Black man, I had an increased risk of developing prostate cancer. And he was unaware of that at the time. And through our conversation, he gave me a few leaflets and I went home. Somewhat puzzled as to the reluctance to give me the PSA. Anyway, to his credit, the GP wrote to me personally, apologized. He'd done some research and asked me to come straight back to the surgery, whereupon I had a PSA and a DRE. Now, my PSA at the time was raised. So as a result of that, I was referred to Southampton General. I was then given a biopsy over in Lymington, came back, had a further biopsy, and it was established, fortunately for me, that I didn't have prostate cancer, but I did have an enlarged prostate. Now, there are tablets you can take to help with that particular condition. However, I decided not to. I decided not to take the tablets, and I looked at my diet. I looked at my exercise regime. I made some changes, and over about, I would say, it took about 2 to 3 years. My PSA went from, at its highest, it was 19. At my last PSA test, which was about 4 months ago, it was 3.2. So there has been a change. And I would say a change that has been for the better. I no longer have symptoms. But that was my experience. Of course, for other people, that kind of process may not work. But for me, that's how it worked out. So as part of Black History Month South, we applied, I wanted to get this message out that there's an increased risk for Black men from West African and Afro-Caribbean backgrounds for prostate cancer. So we have, through the year, Black History Month South, we effectively run various initiatives through the year. And then we have our Black History Month, which comes in October, and we do all our events and everything around that. But through the year, we like to have various things running. And so we applied for some funding through Communities Against Cancer, and the Wessex Cancer Alliance gave us, were very kind and funded a decent amount of money for us to run the project, which we're doing through the rest of this year. So we started in November. We'll be running a second phase of our campaign halfway through this month, through the middle of February, and we'll be running various initiatives right the way through till October again this year. If anybody has anything they want to talk to me about regarding Black history or anything to do with the prostate cancer initiative we're running at the moment, get in touch with us, get in touch with Gemma. You can reach me. I'm very, very accessible. So let's move on from that. Gemma, Louise, are there any questions or comments in the chat for me to answer?
Hi Lou, thank you for that. There aren't any specifically to you at the moment, but there is one about why is there no screening programme for prostate cancer? And I wondered whether either Susan or Dr. Richard Root would like to take that one. If one of you want to put your hand up and we can go with that. Susan, thank you.
Yes, so that's absolutely true. As I mentioned earlier, we don't have a national screening programme. And that's because, unfortunately, the PSA, as Richard mentioned earlier, simply isn't good enough at identifying cancer. And the PSA can be raised due to other conditions, non-cancerous conditions, such as enlargement or something called prostatitis, which is inflammation of the prostate, or can also be raised due to an infection, so if a man has a urinary infection, etc. So it just isn't good enough at identifying prostate cancer to be used in isolation. But there is a good deal of research going on internationally, and indeed we're funding some important research ventures to try and find a better way of identifying prostate cancer as early as possible. But the PSA just isn't it, I'm afraid. But it's all we've got at the moment, so we absolutely need to be using that.
Thank you very much, Susan. And Lou, that's everything for now. There are a few other questions, but I'll let us move on and we'll take those a bit later on.
Thank you, Gemma. And thank you to everyone for these brilliant questions and comments that are coming through. I'm going to move us on again, as I'm aware time is moving on. And next up, we have Professor Frank Chinegwando, who is going to give us a bit of information about the what next if your PSA does indicate prostate cancer and further tests confirm this. Frank, what happens next? What treatments are there and how successful are they?
Yes, thank you very much, Lou. Thank you for the opportunity to share in this wonderfully informative event. I've been trying to answer various questions in the chat, but the whole thing is quite a big topic. I'll just, for now, restrict myself to what happens when you are referred to specialist care. So I'm a urologist, I'm based in London, and the most common type of referral I would get would be the GP writes in to me saying, Mr. So-and-so's PSA has been found to be raised. Being raised means above 3, although it does depend on your age. So a younger man, his normal PSA may be 2 to 2.5. A man in his 70s, you'll accept a PSA of 5 or 6, because as you age, the prostate grows. But so if I get a referral that this man's PSA is raised for age, then we would see the man within 2 weeks. So this counts as an urgent referral. The rectal examination, we don't necessarily have to do that. I think in most instances, it doesn't really add a great deal. And so if the man doesn't want a rectal examination, it's not a big deal at all. So what next? The first thing we do now is to organize an MRI scan of the prostate. It's a special MRI called a multi-parametric MRI of the prostate. This involves, takes about 40 minutes to do, going through the scanner. The man gets an injection, which shows up abnormal areas within the prostate gland. And then if there are abnormal looking areas on the MRI scan, then the next step in the diagnostic pathway is to organize a prostate biopsy. There's 2 ways of doing a prostate biopsy. There's what has been the traditional way, which is a transrectal biopsy, which means there's an ultrasound probe put into the back passage and a needle passed alongside it to take samples of the prostate gland. Many of us are moving away from that particular way of biopsying the prostate because of the risk of infection. And most of us now are doing what we call transperineal biopsies, which can be done under a local anesthetic. So the needle to take the samples of the prostate goes through the perineum. The perineum is the skin behind the back, behind the testicles, in front of the anus. That's the perineum. That's what you actually sit on, apart from your buttocks. So we would do a prostate biopsy, and commonly we would take samples from the right side of the prostate and the left side, maybe 12 samples from each side, and particularly putting our needle into the areas where the MRI scan has suggested looks abnormal. Now, if the result comes back usually about 2 weeks later, if it comes back as showing prostate cancer, then depending on how much prostate cancer there is and how nasty the prostate cancer cells look will depend on what treatment we recommend for that man. Importantly to say that every prostate cancer diagnosis goes through a multidisciplinary team meeting, whereby you have urologists, you have oncologists, you have nurse specialists, you have radiologists, you have pathologists who meet every week and go through all the new diagnoses of prostate cancer and come to some sort of consensus as what may be the treatment options for that man. So when that man with his partner or family members sees the urologist, it's not just that urologist's decision as to what the best treatment is for that man. There has been a team discussion. The treatments range from active surveillance, which is a close monitoring, because not all prostate cancers need treating. Not all prostate cancers are going to get out of hand. So for certain prostate cancers, and that's based on the results we get from the pathologist who has looked at the specimen, for certain prostate cancers, you can just monitor quite closely by doing a PSA blood test every 3 months and an MRI once a year. And if there's some change in those, you can rebiopsy the man. And if the prostate cancer looks worse, then you can go in with your more radical treatments. So active surveillance, probably 1/3 of men we diagnose now, because it's caught earlier than it used to be, they're on active surveillance. Now, if active surveillance isn't suitable, then we have various options which are really good at dealing with prostate cancer. So we have radical prostatectomy. This is an operation where you can remove the prostate gland in its entirety. We also have external radiation, where high energy rays are fired down onto the prostate a bit at a time over a period of weeks. to destroy the prostate cancer without having to physically remove it. We also have a treatment called brachytherapy. And brachytherapy is where you put radioactive seeds into the prostate where they lodge permanently. This does require an anesthetic. You insert these radioactive pellets into the prostate and they lodge there and give off the radiation locally in the prostate, and that destroys the prostate cancer. So there are a variety of treatments for dealing with early prostate cancer. Now, if unfortunately, by the time the prostate cancer has been diagnosed, it's already spread beyond the prostate, so it's spread to the bones or the liver or the lymph glands. Again, we have good treatments for that, but those treatments are not going to be curative. You can only cure prostate cancer if it's caught early and you apply one of the things I've mentioned, surgery, radiation, and so on. If the cancer has already spread, then there are various drugs, powerful drugs, that will keep it under control for a period of time. And these are hormonal injections, or you can use chemotherapy and so on. So really, the message is to catch the prostate cancer early. And despite the limitations of the PSA blood test, it's the best that we have. And I think if you go along to your GP and say, you know, I'm a black man, I'm 45, I'm worried about my risk of prostate cancer, the only thing that can happen is to have a PSA blood test. There is no other way of finding it early. So if the PSA blood test is raised, despite its limitations, it's still the best thing that we have. And in terms of prostate cancer screening, you know, there's a huge European study that showed if you screen for prostate cancer just using PSA, despite its limitations, you reduce the mortality from prostate cancer by 25%. And I have been battling the Public Health England, Department of Health, and so on for many years. Even with the current technology that we have, with its imperfections, we should be using PSA screening to reduce the mortality from prostate cancer. And if we don't, then the situation will continue in that more and more men will be dying from prostate cancer. By the time we have other, perhaps better technology.
Frank, sorry, we've lost your audio there. Sorry, Frank, your microphone just went for a moment then, sorry.
Oh, sorry.
No, we can hear you again now, sorry.
So I've been arguing for years and years, and I'll carry on doing so. We have to use the tools that we have to screen for prostate cancer, especially when it's double the incidence in black men. And we are doing black men a complete disfavor by not advocating a screening program for that. So in the absence of a screening program, these events are so useful and so helpful. So it beholds the men to know about their prostates and go along and ask for it, and hopefully not be turned down. Thank you.
Thank you, Frank. That is such a great message, I have to say, really informative. And you speak with passion, and it's inspiring. And I have to say, if you know, for anyone listening, if you know family members, you've got friends, tell them, get tested. The tools we have, that's what I've taken away from that today. Use the tools we have. It's fantastic. So are there any questions, Gemma, for Frank?
Just two quite specific ones about the descriptions you gave at the beginning, Frank, around the MRI. One was around, do you use the 3T MRI or a less powerful one? I don't know what your knowledge is on that one. Yeah. And also around the transperineal biopsy, is that done under local or general anaesthetic?
Yeah. So in terms of the MRI, a 1.5 Tesla machine is perfectly good enough to give you the information that you require. Okay. In terms of spotting the abnormal areas, a 3T doesn't give you that much extra. So we only have a 1.5, and that is perfectly fine. In terms of the transperineal biopsy, When we started doing those, we were doing them under general anesthesia, but now we've got more and more experience and we're very slick at it. We do them under local anesthesia. It depends on the level of local expertise. But certainly we've not done a transrectal biopsy for maybe 3 or 4 years now. Every biopsy we do is transperineal.
Thank you very much. There are a few more questions, but I'm keen that we hear from Hugh before I take any more. So I'll pass back to you, Lou.
Thanks, Gemma, and thank you so much, Frank. I really enjoyed what you said to us today. Our final guest speaker today, who's been waiting very patiently to share his story, is Hugh. Now, Hugh, you've been through the treatment process and you are a prostate cancer survivor. So please, can you tell us your experience?
You are muted at the moment, Hugh, but if you want to unmute yourself, I'll let you know when you've done it. Should be at the bottom left of your screen.
There we go. Got it.
There we go. We can hear you when you're ready, Hugh. Thank you.
Thank you, Lou. Thank you for the introduction. It is indeed a pleasure to be part of this very special event. As mentioned, I am a prostate cancer survivor, and because of that, I too would like to emphasize the importance of having oneself checked at the very earliest of opportunities and following that process through, because it could save your life. I was diagnosed with prostate cancer in February 2014. And although I was monitored since 1999 and followed regularly, it still came as a shock to me when I was diagnosed with prostate cancer. I remember the consultant said to us, my wife was with me, Hugh, you now have a new diagnosis, prostate cancer. Blew me down. I was shocked. I was stunned. I couldn't believe my ears. And the thoughts that was running through my head were, am I going to die? How much time have I got left? Has it been caught in time? And is it treatable? And I was thinking, what would become of my family? And also my wife who was with me was becoming quite upset, tearful at this time. And I remember I turned to the consultant and I said to him, are you sure? Is this true? Is it right? Now, my consultant, who's obviously been used to situations like this, was very reassuring, was very supportive. And I can say that by the time I left that meeting, that consultation, we were armed with all the necessary information to help us make the decision about what's my best option, as you heard earlier. And with the help of the consultant and the clinical team, it was felt that my best option was the radical prostatectomy, which was done by keyhole surgery 2 months later in April 2014. Now, between the diagnosis date and the surgical date, I was still continually being checked because there was some suspicion that it could have spread and it may have gone to my bones. So I did have a CT scan and a bone scan. And I also remember discussing with the consultant later, because of the concern, that if it had spread to my bones, that my life expectancy could be much reduced. So you can imagine the panic, the fear, concern at that time. So I was very, very worried and naturally looking forward to a good outcome. Unfortunately, because of constraints now, the time constraints, I can't go into the detail. But suffice to say that on the morning of the surgery, I was seen yet again by the consultant and also the anesthetist, who came by and checked that all was well to proceed. And next thing I knew, I woke up in recovery with a catheter, a drain, and a bag. Next thing I knew, I was back on the ward, and I was encouraged to drink plenty of fluid to flush things through. The consultant came by that evening, I remembered, and he came to let me know that things went well, the surgery was okay, and there was no need for any further concern. On reflection, I can say that my recovery from surgery was quite quick because I was discharged home the very next day. And I actually lived close to the hospital at the time, so I walked home with my wife. And I remember my post-op care was very good, it was excellent. And I recall the nurse came out to see me at home to check that all was well, to check my urinary output, to check that the catheter was draining well, and also the operation sites, the dressings, and also to check to see whether there was any discomfort or any pain. I don't remember having much pain, but I did have some discomfort, which I took Panadol for. About 2 weeks later, I had the drain removed. And about 3 weeks after surgery, the catheter and the bag was removed. And I recall that when that was removed, I had to show that I could pass urine naturally before I was allowed home. And one of the things they advised me to do at that point was to remember to do your pelvic floor exercises, because this is very important to say, to help you regain your bladder control. And it took me about 5 months before I could do that. Now, I would like to say that right now I feel as healthy as anything. My PSA, 8 years on, remains undetectable. Undetectable. I do not take any medicine of any type, and I do my PSA only once a year. So that is the situation for me right now. My saving grace, I believe, is that I followed the process. When I noticed that I had some signs and symptoms, I saw the doctor. I got myself into the system, as I would call it, which led to my early diagnosis and my prompt surgical treatment. So like others have already said, the advice would be to get yourself checked as early as is possible and follow the process. Early intervention is the key, and that would lead to a healthier outcome. Thank you for listening. I heard a bit there. Thank you.
Thank you, Hugh. That's a heartwarming story. I'm so glad that your recovery has been so successful. So time's moving on fairly quickly. So I'm just going to ask Louise to share any new questions that may have entered into the chat that we can take at this point. Panel, you can, I think we're going to speak to the panel in general, and hopefully you can quickly pop your hand up if you think it's relevant to you.
Thanks, Lou. Yeah, Louise is just going to bring you all on screen so we can see you all. It has been a really enlightening conversation, so thank you very much. We've had quite a lot of questions. We're not going to be able to cover them all in the next 10 minutes, but as Lou explained at the beginning of the webinar, we will share them in a follow-up email. So your questions have all been noted. If we don't ask them now, don't think we've forgotten you. One of the questions that's coming is around the survival rates or mortality around prostate cancer. If you want to pop your hand up and let me know who wants to take that around survival rates. Richard, over to you. Thank you.
So overall, the 10-year survival rate is 78%, which is a really encouraging level. So it really does focus the mind that get tested, get checked, because even if there is a prostate cancer there, there's a 78% chance you'll still be with us in 10 years' time.
Wonderful. Thank you, Richard. The next one is, what protective or safety measures could one practice to avoid prostate cancer or reduce its growth as age takes its toll? Who would like to go for that one? Go on, Professor Frank, thank you.
Yeah, so I think as Susan said, you know, we don't really have a proven means of prevention. However, there are certain clues to things that may help, either in reducing the risk of developing prostate cancer or may help in slowing the progression. So keeping your weight down, that's important. A diet with lots of green vegetables, I think that's important. Exercise, sunlight, which is where the whole vitamin D story comes in. You know, there's a whole story about vitamin D being protective and or slowing down the progression of prostate cancer. And one of the things that I tell young audiences is that there is a link between sexually transmittable diseases when you're young, setting up chronic inflammation in your prostate, and a higher risk of prostate cancer when you get older. So when I'm talking to younger people, and by younger I mean men and women under 30, I say use a condom.
Go on mute.
Thank you. Did somebody else want to come in on that at all, or? The next question is around a symptom, and the question is impotence a red flag for prostate cancer? Would somebody like to take that one? Richard, thank you.
Yeah, so if you are having problems in the bedroom department, always good to go to speak to your GP, and as part of the workup for that, a PSA would be done routinely because it can be a sign of prostate cancer. The vast majority of cases it won't be, but again, it can be, and because it can be, your GP will check you out, and that would include a PSA.
Thank you very much, Richard. Another one which, Frank, I know you've answered in the chat already, but I think it was privately, so I'm going to ask it again, and if you could just explain your answer, was about the link between, or is there a link between prostate and testicular cancer?
There is no link. Yeah. That's a short answer.
Nice and straightforward.
Testicular cancer is a young man's ailment. Prostate is kind of older men. And the other thing that I wrote was that testicular cancer is very uncommon in Black men for reasons that we don't understand. I think in my entire career, I may have seen one, perhaps two Black men with testicular cancer, whereas it's not that unusual in white men.
Brilliant, thank you. Susan, did you want to add to that?
No, sorry, not to that particular part. I think Frank has really answered that question already. I just wanted to very quickly, because we're running out of time, just share a very important trial called the Profile Trial with everybody listening today, and we'd be very appreciative if you could share this further. It's a study that could greatly improve our understanding of a Black man's risk, and it's the first of its kind, certainly in the UK. So we're looking for Black men between the ages of 40 and 69 to put themselves forward to take part in this trial. It means that men would be, for a 5-year period, very closely monitored for signs of prostate cancer. And the researchers will also be looking for any possible genetic changes that might be present within DNA, looking at blood, etc. And if any man would be interested in taking part in this, they would need to be able to travel to London on occasions. Travel expenses would be reimbursed, but it's a really good opportunity to mention this, because unless we understand more, we can't move to be working towards developing better ways of finding people at risk, and also to develop better tests and novel treatments, which ultimately could save life. So the links to the trials, researchers will be shared with the follow-up email, and you're very welcome to give them a call or look on our website, Prostate Cancer UK, to find out more about this very important trial. Just really needed to get that over. Thank you.
Thank you, Susan. And we will share all the links to access to that profile study and to some of the other information that's been shared. I see in the chat we've got Picasso with us here today, Prostate Cancer Support Organisation, and we've also got some other representatives from Prostate Cancer UK who have shared links and PDFs in the chat as well. All of that will go in our follow-up email, so please don't worry if you can't access the chat box at the moment, or if you're struggling to find that particular message. We will summarise everything, and thank you all for sharing that in the chat. Lou, I'm going to hand back to you to wrap up, as we've only got 3 minutes to go.
Thank you, Gemma. So I think from the level of questioning and different aspects of prostate cancer we managed to cover in this webinar, it's safe to say that we're all leaving wiser and more knowledgeable than we were when we started. I want to thank you all for listening, watching and taking part. Sorry about that, I muted myself. And also for your really great comments and questions. Thank you to all our guests. We worked our way through the prostate cancer journey, learning from Susan about prostate cancer. Dr. Richard Roop described the prostate itself and signs and symptoms. Then about the PSA test and personal experience from Duke and myself. Professor Frank kindly described to us about treatments and living with and beyond prostate cancer, and Hugh has shared his cancer experience with us too. I hope you found this interesting and useful. There have been lots of questions, and we will be sharing the answers after this webinar. We'll also send links for further reading, useful information, and ways to access support, which is more important, should you or your loved ones ever need it. We will also be sharing details on how you can keep in touch. And if you wish to be part of any further prostate cancer campaign work in Wessex, we will provide details of how you can sign up in the email as well. So thank you to Gemma, Louise and the team for keeping things running smoothly, and to all of you for joining us. So from me, Lou Taylor, enjoy the rest of your day. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Lou.